Morning, guys. Today is Thursday, May 23rd, and we're here with QHSC training, identification, and initial management of pediatric sepsis with Dr. Sambi Chaka, Dr. Nagito, and Mr. Eligape. And I think we're going to start with Dr. Nagito, correct?
Yes.
Okay, you can go ahead.
Good morning, everyone. So today we're gonna discuss the identification and initial management of pediatric sepsis. Last year we covered neonatal sepsis, so our goal here is to focus on mostly pediatric patients over a month old. So my co-presenters and everyone will introduce themselves. I'm a pediatric hospitalist and also have board certification in general pediatric. I work mostly in Delaware and work with NIMWAS and Christiana Healthcare System, and they have no financial disclosure. So our objectives to looking at the global burden of sepsis in pediatric in general population, definition of pediatric sepsis. We'll also look at presentation of pediatric sepsis in terms of signs and symptoms. Dr. Sambi Chaka will talk about management of sepsis in pediatric, and then Dr. Urasa will talk about prevention in sepsis and sepsis-related mortality. Next slide. So in 2020, according to WHO and Dr. Weiss et al., it's estimated almost 50 million cases of sepsis happening globally. About 11 million of those results into death. Almost half of the sepsis that happen worldwide occurs in children at the age of 5. So you can see the importance of knowing what sepsis and how we can manage. And sepsis is a leading cause of morbidity and mortality, and also healthcare utilization for children worldwide. Next. So depending on different factors, either severity of illness, other risk, comorbidity factors, and then of course, the location in the world, mortality of sepsis ranges somewhere between 4 to 50%. There's a significant regional disparities. Of course, people in high-income countries, they have less death compared to the ones in low-income areas. And most of the death happen within the first 72 hours. So initial management is key to decrease the mortality. And most of the death in pediatric, it happened because of the shock and multiple organ dysfunction. So be able to identify shock or septic shock in pediatric and the other organ dysfunction and then intervene, that will help us make a difference. Next. There's one study was done in United Kingdom. I found that more than 50% of the death occur within 24 hours. Half of this death happen before the patient get transferred to ICU. So whenever they show up in our healthcare facilities or in emergency room, it's important to intervene early and aggressive to prevent mortality. And in terms of financial burden, there was one study that was reported in high-income country. So on average, it costs about more than $32,000 per patient with the sepsis for every hospitalization. So we can do the math in people who are spending days in a hospital for sepsis, then how much it's going to increase in terms of healthcare costs. Next. So in 2001, Society of Critical Care Medicine and European Society of Intensive Care Medicine, they came up with a campaign to help decrease the mortality and morbidity from sepsis. So they formed what we call Surviving Sepsis Campaign. I'm sure everyone has seen this before, and we'll talk in details later. Next slide. The Surviving Sepsis Campaign primary aim was to develop evidence-based guidelines and recommendation for resuscitation and management for patients with sepsis, including septic shock and sepsis-associated organ dysfunction. And those at the beginning was mainly focused on adults. There was no really pediatric guidelines, so most of the guidelines in pediatric were just derived or basically estimated based on adult studies. The initial guidelines for surviving sepsis campaign were published in 2004. Next. In 2005, so Pediatric Sepsis Consensus Congress, they standardized the definition of sepsis for pediatric, but as I said, they based mostly on adult data. There was no studies done in pediatric. So during this time, they defined what is sepsis, what is severe sepsis, and then what is septic shock. And then they changed the definition from the adults based on physiology and different vital sign ranges in different age group in pediatric. So since then, there have been studies try to update the definition and try to focus more on pediatric population. Next. So in 2005, there was a first definition of sepsis in pediatric was given. So sepsis is defined as a life-threatening organ dysfunction caused by dysregulated host response to infection. And this is focusing on kids or babies who are at least 37-week gestation when they're born to 18 years of age. But the difficult thing with a pediatric is that, of course, different age group have different vital signs. So if you say heart rate greater than X and Y, and then if you are 2-month-old, it's different when you are a year old, it's different when you're 17 years old. So that was a challenge. And then, of course, our physiological reserve is different. So kids know how to trick us. They will look really well, and then before you know it, they'll crash fast on you. Next. So, but either way, a big thing to take away from this is just to be able to recognize when you see a patient who is sick, who is not. So you can see the picture on the left. That's clear. If you walk in the room, you see a patient like that, you know he's not feeling well. So things need to move fast. Where the other one on the right, she's cute. She's looking at you. Then if she came with a fever, at least you could take your time, get more history and try to find what's going on. But the one on the left, I anticipate if they walk in the room, you could hear a quick history, but merely listen, take the vital signs, and intervene as quick as you can. Next. So in 2005, the definition for sepsis, severe sepsis, and septic shock were published. So sepsis, basically, there is a confirmed or suspect invasive infection, and there are at least 2 age-based systemic inflammatory response syndrome, SIRS, criteria. So it could be a fever or hypothermia. They could have tachycardia, tachypnea, bandemia, or leukocytosis. So you have suspected infection, and then you have 2 of the SIRS I mentioned there, then we'll call you someone has sepsis. But again, with the kids, most of the time they come with a viral something, they'll come with a fever. So to decide if it's just a simple virus versus invasive infection, sometimes it's a challenge. And severe sepsis, that means there is at least 2 or more of non-cardiovascular organ system. So if it has, kidney injury and endocrine abnormalities or hematological abnormalities, and they have suspected infection, then they have SIRS criteria, then we'll call them having severe sepsis. Or if they have at least cardiovascular involvement or acute respiratory syndrome, those are also considered having severe sepsis. So sepsis by itself, just SIRS, severe sepsis, now there's some other organ dysfunction. Next. And septic shock, so we talked before, there has to be suspected infection, but now there also circulatory or cellular metabolic dysfunction. And once you get to the level of septic shock, the mortality rate is significantly high. So how would you define a septic shock? You could either have hypotension or poor perfusion. And then hypotension depends on your gestation. I mean, depends on your age. We have different levels we use for systolic blood pressure. These are the ones that were mentioned, 2005, when you're less than 1, it's less than 50, between 1 and 5, less than 60. If you are over 5, if they show up with systolic blood pressure less than 70, that's low, it's start intervening. And then poor perfusion is defined as having prolonged capillary refill or weak and fast pulse. Next. So these tables, I'm sure every institution they have different ranges for vital signs, depends on your age. Majority of them you cannot memorize, so sometimes you have to refer them, but there are some, like someone shows up at the respiratory rate of 70, for the most part it's high unless you're an infant. Next. So this year, the Society of Critical Care Medicine, they formed a Pediatric Sepsis Definition Task Force. And basically, this time, for the first time, they defined pediatric sepsis and septic shock. So now they got rid of severe sepsis because sepsis by itself is already a severe illness. So there's no need to define sepsis and severe sepsis. So they came up with a definition of pediatric sepsis and septic shock. And this came from an international survey, did a systematic review and meta-analysis of more than 3 million electronic health records from 10 different countries on different 4 continents. So this one, I think those Kenya was involved. So at least there's one from low-income area, and I think Bangladesh, where the previous in 2005 was mostly from high-income areas. Next. So the new definition for pediatric sepsis use a scoring system. It's called Phoenix Sepsis Score. So this has better predictive for mortality in children who have suspected or confirmed infection, has higher positive predictable value compared to source criteria, and has higher or similar sensitivity to compared to 2005 criteria. And as I say, this one, it's from different resource settings compared to the previous one where I was more focused on high-income countries. Next. So 2024 sepsis definition. So using this scoring, I will go over in a little bit. So you have two or more score in a child who have confirmed or suspected infection. And there are 8 different systems they use, but the first 4, they're the ones that have associated with a potentially life-threatening dysfunction and mortality. So respiratory, cardiovascular, coagulation or hematology, and neurology. So you have 2 or more points, then we'll call you have sepsis. And then septic shock, if you have more than 1 point from cardiovascular, and then we'll go over what are those points. And then cardiovascular, that involve severe hypertension, lactate that's more than 5, or they need vasoactive medication. Next. So mortality was higher in children who have organ dysfunction in at least one of the 4 respiratory, cardiovascular, coagulation, and neurological organ system. That was not the primary site. So if they come with the urosepsis, it's they have pyelonephritis, they develop sepsis, and then they have respiratory or cardiovascular, or they have coag abnormalities, the mortality is high. So if one of these 4 that it's not a primary site of infection and they're still involved, then your mortality goes up. So the studies have shown that Phoenix sepsis score that's greater than 2 had high inpatient mortality, 7.1% in high income or resource areas, and 28.5% in low resource setting. So the higher the number you have, the higher the mortality. Once you get to septic shock, in areas with high resource area, the mortality is 10.8, and in low resource area, the mortality is 33.5. So as we can see, our goal is to prevent someone going into septic shock. Once you get in septic shock, the mortality rate is significantly high. Next. So this is the simple Phoenix sepsis score. So the respiratory, the first one is like partial arterial pressure. When you look at P over F, and F is FiO2. Those are sometimes hard to get right away, but the bottom one it's SpO2 or oxygen saturation over FiO2. So they have different number they use. If it's less than this, less than 292, you get 1 point. If it's between 149 and 220, or if the patient is on a mechanical ventilation, you get 2 points. And then if it's a ratio of SpO2 over FiO2, it's less than 148, and patient is on mechanical ventilation, you get 3 points. And then for cardiovascular, of course, you get 1 point if your patient is on vasoactive medication. If your lactate is between 5 and 10.9, and then if the maps fall in those ranges. And then a coag or hematology, if your platelets is low, if your INR is elevated, DDAM is elevated, fibrinogen, you get a point. So you can max up to 2. So even if there are 4 of them abnormal, it just maxes 2. And then neurological, if your GCS is less than 10, you get a point. But if you have fixed the pupil, you get 2 points. Next. So as I said, there are 8 systems, but the studies that show mortality significant high when the first 4 systems are involved. You can still score the rest, but don't really count on your total Phoenix scoring. But this one is more for research. I think that some centers are involved in further studies, so they might be updated in the future. But for right now, we use the first 4: respiratory, cardiovascular, coag, and then neurologic. Next. So this is just a summary or more detail from the previous we talked about. So you got respiratory, cardiovascular, and then you have different ranges. Next. Next, to talk about neurologic, then endocrine. If your blood sugar is low, you get a 0. I mean, your blood sugar is low, of course, you get a point. Or if it's really high, you get a point. And then immunologic, if you are absolute neutrophil count, absolute lymphocyte count, they have different ranges. You can get a point based on those. Next. And then the renal, if there's acute kidney injury, also you could get a point. So again, different ages, we have different cutoff on the creatine level. So depending on that, you could make a reference and give a point. And then of course, if there's a liver involvement, your ALT is elevated, you'll get a point. Next. So a quick example, try to play with a scoring system. So now you have a 5-year-old boy who came to the ER with a temp of 39 degrees Celsius, tachycardic, irritability, blood pressure 67/32, with a mean arterial pressure of 43. So it's supposed to be, he received fluid resuscitation, started on the broad spectrum antibiotics. Blood culture is done after an hour, become hypotensive again, and then he started on norepinephrine, which is a vasoactive. A complete blood count is done. It shows that leukocytosis, mild anemia, and the platelets are low, 90. Next. Yeah, so based on this, so using your Phoenix sepsis score, so respiratory wires in Romania, no issues, you get 0.2 because patient has low MAP based on the age, and then also has one vasoactive med. So right there, get 2 points, and then has low platelets, you get 1 point, nothing on the neurologic. So total of 3 points. So based on sepsis criteria, as of 2024, patient is suspected to have infection because of the fever and the clinical presentation, and has at least 2 points on Phoenix sepsis score, and then at least 2 from just the cardiovascular. So in addition to having sepsis, also has septic shock. Next. And then next one is a 6-year-old girl who came to PCP and then was sent to the ER because of hypoxia. She has 3 days of decreased appetite, cough, and fever. Vital signs had a temp of 38.4, tachycardic 142, tachypneic 42, blood pressure is 72/36, with a MAP of 48. Her SATs is 90% in Romania. That's her weight. She appears sick but oriented. Labs, she got bandemia 20%, platelets are normal, coags, MUD, AKI, creatinine of 1.56, BUN 48, lactate was 3. So she's put on nasal cannula 3 liters, FiO2 of 35%. And that's our X-ray. We can see on the right lower lobe, there's infiltrate, so clearly has pneumonia. Next. So based on the scoring, so because patient is on respiratory support, and when you do the calculation, so she has 90%, her oxygen saturation is 90, and her FiO2 is 35%. So you do the math, comes as 257. So that one give her 1 point. In terms of cardiovascular wise, her MAP is low, I think. Yeah, it's 48. It's supposed to be 49 or above. So she ended up having 1 point on that. Nothing on coags, neurologicals, nothing. So 2 points. So based on this, and has pneumonia and has at least 2 points on sepsis scoring. So has a sepsis. Next. So calculating mean arterial pressure, sometimes it could be tricky. I mean, if you have a arterial line, you could do continuous monitoring that way, or you could just do your blood pressure, the mean blood pressure you get. Alternative, there's this one resource, they say you could calculate, you take your diastolic plus systolic minus diastolic over 3. So once you do the math, and then you refer the table, depends on the age, what's their mean, and then you go from there. Next. Presentation, of course, depends on the site and the source of infection. Of course, the age, as I said, the little ones sometimes they'll come with fever, doesn't mean they have fever sepsis. And then depending on your location, there are different organisms that affect population differently, high income areas, Asia, Africa. So if someone shows up, I'm sure the provider that usually aware, like, okay, this could be, I don't know, malaria, this could be, I don't know, influenza, or this could be something else. So depending on your area, then of course, their presentation may vary. But either way, sepsis could be caused from a bacterial infection, which is the most common, but also viruses, parasite, fungi, they also could cause sepsis. Highest risk is usually younger children. The younger you are, the higher the risk. If a patient is not immunized or under-immunized, they're higher risk, immunocompromised, of course, and if they have other comorbid conditions. So could present with like this severe skin infection that, if not well managed, could result into sepsis, pneumonia. Of course, if there's a delay in care, that could result into severe sepsis. Next. Common ones, of course, fever, temperature greater than 38, it's a fever. And if you're a little bit older, of course, 38.3. Some they'll present with hypothermia, especially the infant period within the first few months of life. Poor feeding is a big one. So usually one of the this just teaching I told the parents, like, if your baby's not eating, they're sick until proven otherwise. Sometimes the temp might be fine or a little bit low, but an infant, you go home, all of a sudden, a week later, they don't want to eat, they need to be seen. Some they might present with irritability or just inappropriate cry. It could be drowsiness, difficult to arouse, lethargic. Some could be confused. Some with a severe infection might have seizure, and of course, some with acute kidney injury might have decreased urine output. Next. And then, as we know, tachycardia and tachypnea could be non-specific in pediatric population. Tachycardia could be because of fever, so control the fever and then reassess. It could be the environment if they're anxious. Also could present with a little bit tachycardia, tachypnea. So make sure you let them settle down before you can make the decision if they're truly tachycardia or tachypnea. Some they might have dehydration or pain. That's why they have tachycardia and tachypnea. And then, of course, anemia, you could present with tachycardia. So it's important just before we say, oh, yeah, they have tachycardia, tachypnea, we make sure the environment is appropriate. Next. So once you resolve the temperature, if the tachycardia was from the fever, then it should go back to normal. Anyone who presented with tachycardia, despite being well hydrated, fever is under control, pain is under control, worry about infection. And then if infection is suspected, of course, start treating. Because with pediatric, as we learn on pediatric advanced life support, sometimes tachycardia, it could be an initial sign of someone is about to develop hypotension. So once you develop hypotension for septic shock, it's like a late finding. So tachycardia, if it persists, it's that resuscitation because you'll be running behind. I think that's it for me. See you next. Yeah, so could it be sepsis? So this is a little flyer people could use to discuss with the family, like what are the things that are worrisome that someone needs to be seen and evaluated. Thank you.
Hi, everyone. My name is Lilium Sambichaka. I am a pediatrician and an internal medicine physician based out of Delaware, Christiana Care Hospital. And I will be taking over from Dr. Ngido. Dr. Ngido talked about how you identify sepsis. I'm going to focus on how do you manage sepsis in the pediatric population, drawing off of using, the criteria. So just to, as a disclaimer, these are, let me see if I can. These are guidelines and not rules. Management is based on most current best evidence. It, does not replace their clinician's decision-making capacity when you have a unique set of clinical variables. Guidelines are best practice, but approach every case based on your institution and settings, where your hospital is located, the availability of higher level care. So use these as guidelines. I think they apply in various different scenarios, but do not let your clinical decision be trumped by these guidelines. So the first things first in the management of sepsis. One is, identification, which is what Dr. Ngido just talked about. Identify that the patient has sepsis. Do the initial investigations as you're able. Again, depending on your settings, I would not delay care, just waiting for investigations that you might not have access to. The use of broad spectrum medications, whether it's antibiotics, antifungals, antiparasitics, antiviral, again, depending on your clinical situation. Fluid resuscitation, when to actually, do fluids, how much fluids, when to initiate vasoactive agents, especially in settings or situations where shock is not responding or fluids are contraindicated, like heart failure patients, or if there's already signs of volume overload in your patient. Controlling the source of the infection if possible. And then continuously monitor vitals along with vital signs, sorry, not things, with any clinical change. Timely delivery of a bundle of therapies. So, we mostly will refer to this as the sepsis bundle. Improves survival. Study after study has shown that if you have bundled sepsis protocols, survival will be improved because care will be standardized. And that usually includes, blood cultures, fluid boluses, and the initiation of antibiotics rapidly. Each institution should develop systematic approach for screening, for timely recognition and management of sepsis, septic shock, and other sepsis-associated organ dysfunction tailored to their resources. We know even within the United States, where I'm located, it depends on which hospital you're at, where, are you in like urban area? Are you in a rural area? What kind of resources are available to you? But as long as you have a systematic approach that everybody is following, then you will be able to recognize sepsis in a timely manner. You will be able to initiate management in a timely manner and save lives. I wanted to focus the majority of my talk on just the thinking of this from a systematic approach and as an algorithm. I love algorithms because algorithms standardize care. There's very little room for deviation. Patients are treated the exact same way. People get used to doing things the exact same way with associated evidence. So I will start on the left part of the screen. So this is the initial resuscitation algorithm for children. The first thing is you screen. Do I have suspected sepsis or do I have septic shock? If you have suspected sepsis, then you expedite your diagnostic evaluation. If your diagnostic evaluation supports associated sepsis with sepsis-associated organ damage, then immediately you get access. You collect blood cultures if you're able at your institution. If not, I would not waste time trying to collect blood cultures. That will not change management in that instant. You start empiric broad spectrum antibiotics or antifungals, antivirals, depending on your patient. So if they're immunocompromised, if you suspect there's a viral infection, if you're suspecting there's a parasitic infection associated, start the appropriate antibiotics. If you're able to, you measure the lactate. I know some places do not have ability to measure lactate, but if you're able to get a point of care lactate, you administer fluids if shock is present. And there's an asterisk there because the amount of fluids does make a difference. If it's refractory shock, that's not fluid responsive, or if there's contraindication to giving more fluids, then you start vasoactive agents. The next area is respiratory support. So assess for pediatric acute respiratory distress. Infection source is controlled. You're giving fluid and vasoactive medication titration, and you just continue hemodynamic monitoring if you're able to. The key thing is if, antibiotics within 1 hour of initial recognition of septic shock. That is key. That will save lives. Fluid antibiotics. If you're still, your patient is not in shock and you're still investigating the source of the infection, I would still argue that antibiotics within the first hour is ideal, but within 3 hours of initial suspicion of sepsis, at least you should be able to, you should be starting some sort of antibiotic while you're waiting for more investigations. And moving on to the right side, And I don't have a pointer, I'm sorry. So just bear with me. So at the very top where it says fluid and vasoactive inotrope management algorithm for children. Again, this algorithm part is I find this very helpful because it tells you like what kind of health system are you in. Do you have a pediatric ICU? Are you like in a remote area where you don't have a lot of resources available to you? So if you're in a healthcare system without an intensive care, if you see abnormal perfusion with hypotension, if you see signs of fluid overload, if you see that signs of fluid overload are absent, the 10 to 20 ml per kilo bolus is probably sufficient to start you on, because you don't want to give too much fluid if the patient does not need that much fluid. Again, assess the hemodynamic response to fluids. Repeat the fluid bolus, again, 10 to 20, until the hypotension resolves or you see signs of fluid overload develop. Continue to assess the cardiac function. And then consider, if you're able at your facility, consider starting a vasoactive agent, epinephrine or no epinephrine, if the hypotension persists. That's after you've given 40 mLs per kilo of fluid. Obviously, start sooner. If you notice, do not just wait and give fluids until you get to 40 mLs per kilo if your patient is showing signs of volume overload. The second part is if you have abnormal perfusion, but you do not have hypotension. So the blood pressure is fine, the mean arterial pressure is fine. Do not give fluid boluses unless there are signs of dehydration, or if you have a child that has like ongoing fluid losses, they're vomiting, they're having like profuse diarrhea, you can start them on maintenance fluids. Continue to monitor their hemodynamics closely. If you notice that they're changing and worsening compared to when you last evaluated them, then at that point, you can consider adding on a vasoactive inotrope. The extreme part, the other part is, if you're in a healthcare system and you have an ICU, if you have abnormal perfusion with or without hypotension, again, if you have signs of volume overload, if signs of volume overload are absent, then again, 10 per kilo, 20 to 20 per kilo initial bolus. You repeat that, you continue to assess the hemodynamics to see if the patient is fluid responsive, consider additional fluids until shock resolves or signs of volume overload develop. Again, in summary, do they have signs of hypoperfusion? Yes or no? How's their blood pressure? Are they hypotensive? Start with fluid boluses. If they're not hypotensive, then you probably would be fine with starting maintenance fluids and continuing to reassess. And then if you see signs of volume overload and they're not responding to fluids, then you start vasoactive agents. If they're responding to fluids, make sure at least you get them up to 40 mLs per kilo before you start a vasoactive agent. And then you keep, reassessing, is the shock resolved, is perfusion improved. Do not give more fluids if their shock is resolved or the perfusion is improved. You can now put them on maintenance fluids. And then you just keep monitoring for any signs or symptoms of recurrent shock. So that I think the most important thing is you've done the identification. If you're going to use the Phoenix scoring system, use that. And then the most important thing is you have to start the initial management. Some of the investigations that you could do, depending on your facility, blood cultures, complete blood count or full blood picture. You can do a complete metabolic panel, lactate if it's available, because this can be a marker of perfusion, and all the other studies pertinent depending on what your history and your clinical presentation looks like. Just a little bit about lactate. The lactate levels are not specific, but they do provide a quantifiable surrogate for tissue hypoxia. So they should be interpreted as part of a more comprehensive assessment of the clinical picture. Do not rely on them solely. We do know from studies that a lactate that's greater than 2 millimolars per liter is significant. The mortality rate can be high for children. And so it's a good surrogate marker for tissue hypoperfusion, but it should not be solely relied on. And this is just me summarizing now. Patients with septic shock, you start antimicrobial therapy as soon as possible, ideally within 1 hour. Patients with sepsis-associated organ dysfunction, but without shock, again, start antimicrobial therapy as soon as possible after you evaluated them, no more than 3 hours. Do not delay antibiotics for blood cultures. We have new molecular technology right now, and hopefully it will be more like worldwide, where we can identify pathogens relatively quickly compared to when we had to wait like days on end to get that. The medications, again, empiric broad spectrum therapy with 1 or more antimicrobials to cover your most likely pathogen, depending on your site of infection, what goes on in your local community, your patient's age, and the comorbidities. Consider invasive fungal infections in the immunocompromised and the preterm infants. Consider healthcare-associated infections, which can often be resistant to multiple drugs and can lead to like rapid clinical deterioration. I would not belabor this. This is just, I would say, refer to what your hospital guidelines, your national guidelines for which antibiotics would work in your environment. But, for our case, we always cover, for gram-positive and gram-negatives. And depending on the clinical condition, we use like broader spectrum antibiotics, or we add antivirals or antifungals, depending on the clinical condition. Again, septic shock, fluid resuscitation, no shock maintenance fluid. That would be the takeaway from this slide. Vasoactive agents, epinephrine or norepinephrine or dopamine can be used. Again, refer to what you have available to you, but these are usually the initial drugs that we use. Fluid resuscitation, 40 to 60 mLs per kilo. If they continue to have evidence of abnormal perfusion. Once you're getting to a fluid bolus of like greater than 40, just monitor for volume overload, because that's a patient that you might have to intubate, or, just avoid getting them to that spot and start them with a vasoactive agent to support their blood pressure. Hydrocortisone to treat children with septic shock is an option if adequate fluid resuscitation and vasopressor therapy is not able to restore hemodynamic stability. Consider mechanical ventilation if you're able. Control and treat the source of infection, and treat other complications, hypoglycemia, hypocalcemia, or other, reverse like other things that could contribute to deterioration. Again, just a summary of what, encapsulates the management of sepsis. I would say, take a picture of this, especially for those of you that are newer, out of training, and, you can refer to this for your own benefit and the patient's benefit. And now I will pass it on to Dr. Urasa, who will share with us about infection prevention.
Share the screen. Actually, I'm a junior doctor. Currently, I'm located in India. I work as a general practitioner, and I'm just glad to be part of this presentation. And to start with, I would like to remind each one of us that on September 15th is World Sepsis Day, and that's it. Just bring it to your attention. And this year, the main theme is actually focused on closing the gap between diagnosis and management, which is mainly lacking in the resource-limited settings and low-income countries. So yeah, just straight to the presentation. Thank you. Next slide. Yeah, so September 13th, World Sepsis Day. And yeah, the theme this year is to mainly focus on closing the gap between, in diagnostics and management of patients who come in with sepsis. So again, we know that patients with sepsis come at all levels of our healthcare system. They could come at primary level, secondary, or even at tertiary level, and it could be for all departments and all levels of care. So it's important to really integrate a good clinical care from the primary level to the emergency rooms, to the ICUs, and even if at all patients require surgical management, then it should all be timed and well integrated. And this will come only by good communication, maintaining a good continuity of care, and availability of transport, especially in the resource-limited settings. Usually, it's very important to make sure that the primary care is in good communication with the next level of care. And again, transport is a challenge, mainly the resource-limited setting. So by making sure that these things are taken care of, probably you're going to reduce the burden of sepsis complications and the low and middle income countries. Next slide, please. Yeah, so as I said before, implementing preventive measures such as good hand hygiene practice, vaccination programs, improved sanitation and water quality, these are very important. We cannot overemphasize this, especially in the pediatric population who are at the higher risk of acquiring infections and which might complicate with septicemia and septic shock. It's very important to make sure that good preventive measures are in place. And this, I very much insist on the resource-limited settings where the availability of facilities is very limited. And again, community education on the signs and symptoms of infections is important because it's by identifying infections at the early stage that we can prevent septicemia. And this again will lead to early diagnosis and proper management timed, and will improve likelihood of survival, but also reduce the complications. So when patients are admitted in our settings, especially for the pediatric group, monitoring and detecting their clinical status, whether they're deteriorating or not, will help to prevent organ failure and complications, of which Dr. Fabian just presented to us the Phoenix score, which really tells us about the severity of the sepsis and its complications to multiple organs. So by really monitoring patients on the clinical status will help to prevent the complications. Yeah, next slide, please. Yeah, this is another thing that I would like to bring to your attention. As per WHO, for every 1,000 patients admitted, at least 15 of them are going to get sepsis as a complication. So this is very alarming, and we know indeed that for the resource-limited settings such as Tanzania, the sepsis burden is very much higher compared to high-income countries. It's up to 80% of the sepsis cases that are reported globally. They all come from these resource-limited settings, and one of the causes could be because of the inpatient care that patients receive and the absence of aseptic techniques, hand hygiene, and all these things really lead to the increase in the sepsis burden. So we cannot overemphasize really the importance of preventing, because that's the best thing we have right now, considering that the momentum of antimicrobial resistance is really increasing. And another point to insist on is on antimicrobial stewardship. So appropriate use of antibiotics is really crucial. And as much as we need to treat empirically for patients who are coming in with suspected sepsis, it's important also to make sure that we timely halt the use, if at all they are not needed. So at least 48 hours post-admission, patients should be evaluated whether they need the antibiotics or not. And I just finish this slide by, again, bringing to your attention that at least almost 1.3 million deaths that were attributed to, at least 1.3 deaths globally reported were attributed to antimicrobial resistance. So as you can see, the momentum of antimicrobial resistance is increasing, and scientists inventing new antimicrobials are a bit slow compared to the antimicrobial resistance pace. So it's important really to invest more on preventive measures than trying to pace with the treatment. Yeah, next slide. Yeah, so this is a quick summary of preventive techniques. As I said before, there are risk groups. I mean, there are groups of people that are at more risk for acquiring septic infections, and these are the pediatric group, where children are about 1.2 million globally reported to be at risk for sepsis, and 3 million in the neonatal group. So this is a big number contributing to the 30 million that is there globally at risk of sepsis. And you can see that the other groups includes elderly group and the pregnant women, as well as the immunocompromised patients, which again, they're increasing because of the double burden of non-communicable diseases such as diabetes and hypertension. They're all increasing the number of the immunosuppressed people. And therefore, the sepsis burden is probably going to grow in the resource-limited setting unless we invest very much on good preventive measures. So one of the proven ways that have been found to reduce the likelihood of acquiring infections includes hand hygiene techniques, which reduces diarrheal disease to up to 40%. And again, acquiring or having good sanitation of water has been shown to reduce infections or diarrheal illnesses to up to 10%. There are many others that are in this algorithm, but as of now, because of time, I would just like to summarize by saying that the best way to tackle down sepsis probably is by investing in preventive measures. And this should be put in place from community level to the primary care level to the tertiary level. Even at the point where we are surgically managing patients, we should still make sure that our preventive techniques are really very much in place to at least be able to pace with the degree of antimicrobial resistance, which is happening now in the world. So by saying so, I think I'm done with the preventive part, and I would like to show you guys our references in the next slide. And I think I'll take it back. Yeah, next slide, sorry. Yeah, these are our references, and I'd like to take it back to Dr. Fadin or Dr. William to lead us through the next part of the presentation. Probably, please.
Share the poll and have a quick discussion and see if people have questions, concerns, and we could address.
While you're sharing that poll, I just wanted to introduce everybody to Dr. Rasa. Dr. Rasa has he's currently based in India, as he said, but he trained in Tanzania, so he is understands the Tanzania healthcare system, and he'll be joining QHSC and working with Dr. Dorothy and the others on the upcoming medical mission. So we're very excited that he graciously agreed to be a part of this conversation. And we can go ahead and look at the poll.
And then something else to add, Dr. Russell will also be looking at joining pediatric residency. So we're excited for him to be part of future educator and facilitator for QHC. Question was sepsis occur basically just in newborns or low-income countries, anywhere in the world, or high-income countries. I think this was mentioned by Dr. Russell that sepsis occurs everywhere, so it doesn't matter high-income country, low country, adults, kids. So anywhere in the world, there's sepsis. The mortality and morbidity rate depends on your resource. So we have to be looking for sepsis. Right. Question number 2, one of the ways to increase survival from sepsis is developing bundle therapy within an institution, B, misuse antibiotics for every viral illness, C, waiting on the lab results before initiation medication, and D was giving antibiotic at home for a child who's very sick. So the correct answer is going to be developing bundle therapy that was mentioned by Dr. Msambichaka. So every institution can develop, depends on the resource they have, like what kind of the labs they can do, but bundle therapy improves survival. The last one, when I say
Dr. Kido, can I just add that to for the non-clinical, and this obviously some people will probably be viewing this later, but especially in countries where you really don't need a prescription to get antibiotics, I think the misuse of antibiotics for every viral illness is leads to high actually death, because you develop resistance to a lot of the bacteria develops resistance to a lot of antibiotics. And so when you're really, really sick, it becomes a struggle to give you the antibiotic that actually will work. And that can easily result in like premature death just because of the resistance pattern. So I would say viral infections are viral. The antibiotics don't do anything. Just tincture of time and some support here is key.
And then also giving Tylenol or ibuprofen at home, also for someone who's very sick. Because if people, like I just said, I don't know, some runny nose, maybe you could try that. But if they're very sick, they need to be seen by a healthcare provider. Question number 3, for patient in septic shock, antibiotics and IV fluid should be started within 3 hours, 2 hours, 4 hours, as soon as possible within an hour. So Dr. Msambichaka emphasized on this. If you have a shock, within an hour, patient should be getting antibiotics and IV fluid. And if you can do labs, great, but otherwise start with microbial and parasite, depends on what you suspect is going on. But if question number 4, patient with organ dysfunction but not septic shock, treatment should be initiated within 4 hours, 6 hours, 3 hours, 5 hours. So again, it was mentioned by Dr. Msambichaka, if they are not in shock, but you suspected sepsis, start antibiotics and IV fluid within 3 hours. The longer you wait, the higher the mortality. And then question number 5, one way to prevent sepsis-related death is, this was discussed by Dr. Rasa, it's vaccination and hygiene, seek care early, have recognition and treatment at healthcare centers, or all the above. And the correct answer is all the above. So there's different ways we can help to prevent sepsis, prevent infection that does not develop into sepsis and sepsis-related death. So.
And then what are the critical times, I guess, like for, I know you were talking about the child, right? So what is the critical time, let's say, for a child, or what is the critical time for an adult where it gets to the point where it's really serious? Because I think I mentioned it before. I had a friend who actually lost a limb to sepsis. So I was never really sure how long he must have had it in order for it to be that bad.
Yeah, so sometimes it depends on the source or organism, because there are some that are pretty aggressive. I mean, they have some cases where pediatric patient die within hours of presenting because of, or within hours of getting infection. So it depends what the source of infection, the organism. Some they're more aggressive than others, and so it's hard to tell how many hours, unless Dr. Msambichaka or Dr. Russ have in addition to that.
No, I think it's pretty much what you said. It depends on the organism. There's some that are very rapidly progressing, and then there are others that are smoldering, and it just takes time. And those are the ones usually it's like you have this, for days you're not feeling well and you're just nursing things at home, and then all of a sudden you crash. But then there's some that within hours, if you don't get to the hospital, it could be bad. So for your friend, I don't know the details, but let's assume your friend was a diabetic and then they ended up with a wound that they were not nursing at home, and all of a sudden the bacteria comes from the surface and finds its way into the bloodstream, and then you get really, really sick. And then when you have sepsis, usually it's like a perfusion issue. So then your body is not delivering oxygen to important parts of your body, and you could have. And if I'm assuming they're an adult, we rarely get these complications in kids, but in adults, you've eaten all your nyamachomas and your high cholesterol foods, and so your arteries are clogged, you have diabetes, you have all these things. So just the outcome, getting loss of perfusion to a limb is highly likely, and sometimes you have to cut it off to save the entire person. You have to cut off the part that's damaged. Otherwise, it would just continue to eat up, and you would die. So difficult decisions that have to be made. The most important thing is, if you're not feeling well, you're passing out, you're losing consciousness, seek, medical attention. And on our part as healthcare providers, it's not delaying the care, because the patient can come to us in a decent amount of time, but then we delay the care, and that's when we get in trouble.
Yeah, just to add to that in summary, from the preventive side, I would say there's always just 3 delays that would happen. One is the patient themselves. They did not identify the symptoms on time. They did not decide on time to seek medical advice. And then that's the first delay. The second delay is probably they delayed, the medical team delayed diagnosing the patient. And after delay of diagnosis, then there's a delay of intervention as well. So it could be one of these 3 things, and it's always fitting to look for the way Dr. Fabian and Dr. Msambichape just highlighted. So in summary, it could be just a delay in some of these, either delay of identifying the problem, or a delay in seeking care, or a delay in the intervention.
Asante kaka Agape.
Sure. Karibu.
Right. I am happy to continue to answer questions, but I'll have to transition to my phone. We have both of us, Dr. Ngido and I, have to drive separate locations for a good 45 minutes to get to work. So I'll transition to the phone. I'm happy to stay on and answer questions, but I'll go off camera.
Asante.
Thank you.
Any last minute question, and then I'll leave Dr. Urasa, or he'll stay on for a little longer, but I have 1 minute. Any other questions from the team?
Oh, a correct answer for number 2. Remember what question number 2 was, Bree?
No,
Question
I have
number
to check.
one way to increase survival from sepsis is by developing a bundle.
Bundle therapy.
Yeah, that was the answer for number 2, developing a bundle therapy. But one person gave an answer to be giving antibiotics at home for a child who is which was incorrect actually.
You're welcome. What do you say, Bree?
I think we're good.
Okay. Well,
Muguzi Bree.
thank you, everyone, and hope to see you guys with the next talk.
Thank you, Dr.
We
Ngido.
appreciate it.
Bye-bye.
Asante, Dr. Urasa.
Asante, karibu Tanzania.
Asante.
Yeah. Thank you, Dr. Urasa. Thank you, Dr. Samichaka.
22.
Karibu. Hakuna matata, hakuna shida. You just come, have fun. Yes.
Indio.
Welcome to India also. I'm in India right now.
Oh, that's right. That's right.
Wherever you like. Yes.
Another journey.
Yes. Okay, bye.
All right.
Okay,
Bye.
bye, guys.
Bye.
Bye.
Done.